Welcome to the special episode from Straight from the Hip. A few weeks ago, I met up with orthopedic hip surgeon, Mr. Karthik Logishetty at UCL to discuss about this exciting new development in young hips, which is ceramic hips resurfacing. So when you think of somebody with OA and who had failed conservative management, other than steroid injection, the natural progression would be looking into referring for a total hip replacement. So for a long time, we had issues with the ceramic hip resurfacing with the metal on metal issues and also allergic reaction, and it was not suitable for many women. However, with the new resurfacing with ceramic, it's really changed the whole landscape, and this can be available for much more patients. So especially young and active who want to get back into high-level sports. So in this podcast, I discuss with Mr. Logishetty the indications, who are the appropriate patient, and how does it compare with other joint replacement. The initial data is really exciting, and many centers in London are already offering this. It's not widely available across the NHS, but I expect that to open up very soon. So this opens up another option for young active patients who want to return back to high-level sports or other athletic activities, and who don't want to go for the full total hip replacement. Let me know your comments, and looking forward to your feedback.
My name's Karthik Logishetty. I'm a hip preservation and hip arthroplasty surgeon. I'm based at University College London Hospital and also Cleveland Clinic London.
So your training path involved a PhD and a clinical lecture at Imperial as well. So how did that research first environment change how you approach a patient in your day-to-day clinical work?
Well, I've started doing research as a medical student, and then pretty much when I became a doctor, I entered this half surgeon, half academic track. So throughout my clinical training, I was doing research at various points. So I think really it's fundamentally not shaped, but it's guided how I've been, managing patients and thinking about things. I think the main thing that allows you to do is to be exposed to people and systems that are challenging the way you think, challenging dogma or the way we're always doing things. And I think you come across some people, and two of the main people I came across in my research journey was Justin Cobb at Imperial and then Johan Witt at UCL at the time. And being around them, spending best part of a decade researching the hip with them, developing implants with them and so on, has inspired me certainly to keep being engaged in research, to keep innovating, to keep developing, to try things out in clinical trials, bring innovation to bench to bedside and so on. And these days, I now see some of the translation of the research I was doing 10, 15 years ago with these great guys, and I'm able to deliver them in clinics. So that's a very satisfying way to get involved with research and see its effects on real people in the community.
Yeah, you worked with top experts like Professor Justin Cobb and also like Johan Witt, all pioneers in their field. What was one of the important pieces of advice you got from any one of them, which you think about when you're in the middle of a complex case?
I think more generally, they are both very resilient people who've had multiple challenges when it comes to research or innovation or their clinical practice. And I think that they have weathered the storm, and it demonstrates that actually things are going to get tough, either in one case or in your career or where you're trying to change practice, but to keep going. The second thing, particularly with these two guys, is that they have an immense dedication to their practice, and the patient comes first, not the research, not the innovation, but actually seeing as many patients as possible, trying to help as many patients as possible. That shapes you as a surgeon, because ultimately the more people you see, the more you learn, the more you develop, and the more people you can help. So I think resilience and the power of helping bring patients first are the two things that those guys have taught me. And I think finally it's the attention to detail. Both in their own way are very meticulous surgeons, and I think as a surgeon it's good to be efficient, it's good to be fast, but actually it's probably most important to, measure twice, cut once.
You see a variety of cases in your hip world. So for listeners, could you sort of give us what are the different type of cases you see from, FA to dysplastic to the resurfacing? So it'll be good to know what sort of range you did.
Yep. Okay. So my practice, as I mentioned earlier, is hip surgery.
Yeah.
And I love being a full spectrum hip surgeon. So that will involve things like regenerative medicine, trying to give longevity to the hip through simple things like injections or physiotherapy or optimizing non-surgical measures. And then in the minimally invasive sector, I'll do hip arthroscopy. That's mainly for femoroacetabular impingement, people with hip impingement. That'll be repairing labrums, moving cams and making femoral heads more spherical, sculpting them so they don't impinge anymore. And then there's the osteotomy work, which involves, I'd say, reorientating bones so that the hip joint can move more congruently and without impingement or without hip dysplasia. And then it's the hip replacement world, the hip arthroplasty world. So that's hip resurfacing, which is when you recap the femoral head with a metal or ceramic material, and the same thing on the acetabular side, the socket side as well. And that's very, very good for people with high demands from their hips. It's like younger people with good bone and so on. And finally, it's the hip replacement, the operation of the century, what we know and love. And I do most of those through the anterior approach and some through the posterior approach as well. And finally, I do a little bit of revision work, but not very much.
Use robotic assistance and 3D planning. So in your experience, has this technology actually changed the outcome for a patient, or does it make the surgery more predictable for the surgeon?
So the question really is about what the clinical value, either for the surgeon or for the patient, all these fancy tools are. So the majority of my hips are not robotically assisted. I navigate most of my hips, and we find that's the most effective, efficient way to actually have a couple of cameras in the case that shows exactly where things are, where things go. A handful of cases, which are complex cases, really benefit from robotics. But actually we find, or I find, my philosophy is that for the most patients with more of a normal hip to start with, robotics probably isn't adding a huge amount of value. 3D planning, however, is very, very important. So for all of our hip arthroscopy cases, for all of my PAOs, they will have 3D surgical plans. So we know where the cuts are going to be, how much correction we can get to make a shallow hip into a not shallow hip, or a retroverted hip into a normally antiverted hip. I think surgical planning is a very good guide. And I'd say watch this space. I think within a few years, we're going to see navigated periacetabular osteotomy being routine. So not only do
So for the straight from the hip audience, how do you manage like what I call the gray zone patient? So a female with some dysplastic and also some impingement who might be a candidate for PAO, but also for scope, and eventually might need a replacement. Those are tricky cases, aren't they? So how do you navigate those?
Yeah, I think they're the challenging cases. They're the ones that shared decision-making is very, very important. And listening carefully to the patient's symptoms and examining them carefully. Because, as you know, Benoy, all hips eventually are going to hurt if you flex, adduct, and rotate them. And differentiating between impingement and instability is a challenge. But usually in the younger patient who's a bit more hypermobile with a good range of motion and that impingement type pain, it's labral pain, it's not impingement pain, they're going to have instability. And those patients with slightly reduced range of motion with classic flexion, adduction, and rotation pain and so on, they tend to be impingers. When you put the CT together, even patients with, let's say, a borderline lateral center edge angle, let's say it's 25 degrees or so, you have to work out, is it the cam that's impinging or it's the labrum that's torn? And more often than not, if you listen to the patient, they will tell you the way they describe their symptoms will differentiate between that. Now, finally, I think some of the work you're doing as well is very interesting, which is dynamic ultrasound. When we're trying to differentiate between instability and impingement, I'm pretty sure that if you do a dynamic ultrasound assessment of the hip, you will see the instability patients and their hips sublux, even if they have a cam, because a cam was incidental. And inversely, patients with impingement, you'll see them impinge early, even if they have a low lateral center edge angle, because the dysplasia was incidental. But I think some dynamic ultrasound assessment's pretty cool, and I think that's going to be more commonplace.
Along with the whole clinical picture, I guess.
Absolutely.
So moving on, one of the main reasons I came today was I'm really excited on the changes in the resurfacing world. So for the audience who are not used to that, who had very brief knowledge on the metal on metal, could you say what has changed the landscape of hip resurfacing, especially for the active individual?
Yeah, well, I think it's worth just for your listeners to have a tiny little look back at history. Then we have to understand that what Derek McMinn invented in the late 1990s and early 2000s with the Birmingham hip, which is a metal-on-metal implant made of cobalt chrome, it was highly successful and it remains a fantastic implant in the bigger sizes. So around about the late 2000s, there was a recall of many metal-on-metal devices because of the metal ions that were leaching from it, because some of them weren't designed appropriately. The Birmingham remained in service, it remained available, until very recently, because it does a really good job. But because in smaller sizes it too was failing, they stopped it in women, almost or over 15 years ago now. So therefore, there's been a little bit of not parity between boys and girls with severe arthritis who are very active, who want a lot from their hips. When the men could have hip resurfacing, the women couldn't in the UK.
Yeah.
So around, let's say, in the late 2000s, when that metal on metal issue was clearly presenting itself, my research supervisor at the time, Justin Cobb, saw how well ceramic was doing. So current generation of ceramic implants called Biolox Delta, it was invented in around 2003 or so. By the late 2000s, we realized that ceramic is a wonderful implant material. The ceramic on ceramic hip resurfacing, when I was his BSc student and then a PhD student with that gang. And then we put that through a clinical trial in around 2016-17. We followed up a few hundred patients for 8-9 years and reported on those results pretty recently. And what we found is that ceramic on ceramic hip resurfacing is a very safe and durable, at least in the short to mid-term, option. And finally, not just for men, I think for women as well, we have that equity of access now. And I think, time will tell, but early results are very promising. We're not seeing, of course, any problems with metal ions because there aren't any. And ceramic on ceramic is the best bearing surface we have. That we now have 25 years experience in total hip, and I'm pretty sure that we're going to see pretty durable results in the hip resurfacing world as well.
So I did look on the research, and that looks really promising with only 2 revisions. Statistics aside, what's the most surprising or valuable thing a patient who had this resurfacing has said to you following their op? How has it changed their life? Because at the end of the day, it's the patient's life and their story, So how did you find dealing with patients after that, the impact for the surgery?
I've had a few patients with interesting stories after hip resurfacing. I think one of the things with hip resurfacing is that patients have already bought into the idea. They want to preserve their bone. They want to do a lot and they expect a lot of themselves and from their implants. So of course you're going to get wonderful pictures 6 months out from surgery of them trying to windsurf, skiing and doing this and that. I think one of the most interesting recent ones actually was a patient who was a pilot or is a pilot and was unable to do all the long haul flights, but also had worn out early because they were spending dozens of hours sitting in a cramped position, slowly grinding their hip away, and seeing them return to getting back to flying planes, doing what they love, but also their profession, was a different one for me to see that picture, but I think also very rewarding.
One of the issues we had previously was like women were not suitable candidates and things like that, Now, do you think are there more women involved in those trials? I saw in that nearly 50% were women. So how do you find, is there any gender difference in the outcomes or is it similar?
No, I think the outcomes are identical thus far. And so that's a huge change, right? Because 5 years ago, 0 women were having this and now we have half of them and they're doing just as well.
So that's and what are the known unknowns? Obviously, there are some complications like the squeaking and the psoas impingement, few things which we don't know about the resurfacing. Obviously, we need more research. So is there something which we need to watch out for in the next 10 to 15 years?
Absolutely. I think you have to think about what could go wrong, I think, with these implants. Fundamentally, the bearing surface, we're talking about ceramic, has always been mounted inside a metal shell on the acetabular side. And on the femoral side, ceramic has been used as a ball that went onto the metal stem that sat in the post. But applying it straight to bone with a coating of hydroxyapatite, still applying it pretty close to the bone, is a novel concept. We are seeing really good osteo-integration of these implants. We're not seeing major, what we call stress shielding, where the implant takes too much of the weight and doesn't distribute it to the bone. I think time will tell regarding, loosening, regarding osteolysis, which means stress shielding. But early signs are good. I think that's number one. Number 2, you've already mentioned about psoas impingement. I think one of the implants has a little cutout groove for that, and that probably is a big difference for women. And then finally, squeaking. Well, in our, in my test with Imperial when we were doing this 10 years ago, we actually put microphones all over people's hips and made them do lots of stuff. And the microphones weren't really able to pick these things up. But we have seen over the years a few of those patients, a handful, less than 1% of those patients, come back and say, in certain positions, I do feel a squeak. So I think really the squeak is a design thing related to some total hip replacements. It doesn't seem to be a big thing at all for hip resurfacing.
Excellent. And for the physiotherapists in our audience, which is the majority, what would be your typical guidance to the patients on the expectations and also the post-op recovery and the rehab timelines? What are those key areas you would go through the patient before the surgery?
Well, I think number one, you and I know that you can't tell patients what to do.
Yeah.
Patients will always, and by as is their right, do what they want to do.
Yeah.
All you can do is advise them and say this isn't ideal. I think with hip resurfacing, particularly uncemented ones, cementless versions, I think you need to make sure it osteo-integrates, meaning that bone grows into the implant, and that can take a few months.
Yeah.
So if we're thinking about a quick timeline,
Yeah.
I tend to give them crutches for a couple of weeks, at least 2 to 4 weeks, just to kind of take the weight off and let them get core stability and strength back in their hip before stumbling and so on. Full weight bearing, but certainly just crutches. And then usually by 4 to 6 weeks, they're off crutches entirely.
Yeah.
And hopefully not doing very much, not trying to push themselves for the first 6 weeks. It can be anterior approach or posterior approach. I think there's pros and cons of both for hip resurfacing. It doesn't seem to make a massive difference in our research in Imperial on that study, on that particular question. And after the 6-week mark, then you can start doing range of motion stuff without weight. But really, you need to get to around about 4 to 6 months before you're signed off from the surgeon. The x-rays look very good and it looks like it's osteo-integrating before you can think about impact stuff.
Yeah.
That's quite a long time for people who've been going at 110 miles an hour, as in the classic resurfacing patient, to say really slow down for 4 to 6 months before you can sign them off. But longer term, like, there are no restrictions, right? They're going to do what they want to do. They want to do rock climbing, they want to go windsurfing or surfing or skiing. I've seen people with ceramic hip resurfacing and metal hip resurfacing go back to football, professional football. So there is no restriction after that.
Is there any advantage of doing the resurfacing through the anterior approach?
It's the same take I have for total hip replacements. The anterior approach probably has small benefits in the early recovery period after a total hip replacement compared to a posterior approach. For the first 6 to 8 weeks, it's faster. But ultimately, you have to have a surgeon that's very facile in doing that. One shouldn't be doing a different approach because they think it might give them better results for the patient or what have you, if they're not able to do it as well as they do their own regular approach. So as a surgeon that does both, for my hip replacements, I tend to do majority as anterior approach. My hip resurfacing patients, the exposure is actually more extensive. You need to see more of the hip. And so therefore the vast majority of those are posterior approach, where actually only the slightly longer, slender females with straightforward tissue access get the anterior, because it's actually technically straightforward thing to do.
And one of the limitations of the study, which, so it's done in large centers with somebody like you who's a high volume surgeon, would you think that might be a limitation for accessibility for patients across the UK, because right now it's limited only to few centers. Do you think that will change?
Listen, I think that people get good at doing complex procedures when they're doing a lot of them. And therefore there is a risk of surgeons doing a handful now and then of technically difficult things, and then the associated problems one sees when one's doing things only occasionally. I think if the surgeon is doing this regularly, it's more likely they're going to be doing it more accurately.
For somebody like an active patient, somebody like me in the 40s, with end-stage OA, failed physio, what would be your mental checklist you used to decide between a resurfacing patient versus a total hip replacement? And are there any absolute contraindication to the H1 system?
Fundamentally, it's about the patient asking them what their beliefs are, what their aspirations are, what they really want from their hip. The majority of people, let's just say someone is in their mid-40s, they're super active, they're asking a lot. They've got really good bone quality. Their biological age, not their actual chronological age, is young. They've got really good bone density, and you can see that on an X-ray scan. You don't need an DEXA scan for that. And they haven't got significant avascular necrosis of their femoral head because it wouldn't support a hip resurfacing. And cognitively, mentally, psychologically, they're up for the challenge of rehab. Then those are the kind of the straightforward reasons to do or suggest you can have a hip resurfacing. But inflammatory arthritis, a lot of AVN, particularly AVN on the medial side of the femoral neck, obesity, smokers, people who may not be up for the challenge of rehab and so on, probably wouldn't then get the benefits of it, and therefore the risks of having a resurfacing outweigh the benefits, because historically the revision rate of a resurfacing has been marginally higher. Now we don't know it's because the patients are doing more or whether it's actually the procedure itself, but if you want to take that risk, you probably should be someone who has that buy-in to the procedure and is biologically a healthy, active person.
How about women who develop severe OA because of dysplastic hip? Is that a problem with resurfacing, or is it case by case?
No, I think in our series of a few hundred patients now, most of those females are dysplastic because young girls get OA because they're dysplastic. So we've not had any change in survivorship based on their sex. Dysplasia, in terms of modest dysplasia appropriate for arthroplasty, is not a contraindication to a hip resurfacing.
Yeah, and this for the therapy colleagues, what would you say is a common misconception we have about hip resurfacing, especially in the post metal on metal era? Because there's a lot of lack of awareness and things like. What would you say to other professionals who are looking into in this space?
I think it's early days, right? You have 7-year data to 10-year data. And if your patient is that high demand patient who's thinking already about hip resurfacing, usually it's something that they're coming to me or to you about. The misconceptions, really, I don't think there's been time enough for misconceptions yet. I think we're in that early understanding phase. So as a hip preservation surgeon, I think preserve first, right?
Yes.
So I can preserve bone rather than taking off the femoral head and neck. I think it's a valuable thing to do. I think we want to preserve people's native bone stock and then do the hip replacement, ideally in 20, 30 years or what have you, if ever. Right?
Yeah.
So fundamentally, my reassurance to people who are skeptical about this stuff is that ceramic is a safe material.
Yes.
It's probably good to preserve bone. The dislocation risk is far lower with hip resurfacing. Function probably is a bit better, but it's confounded a bit by the people we choose. But probably because we have their MET scores, they're doing a bit more.
Do you think in the future we need to compare the ceramic on ceramic versus total hip replacement in a young population? Is that something we'll be planning in the future?
Yeah, we're doing that now. We're recruiting to a randomized clinical trial specifically for total hip replacement versus ceramic hip resurfacing.
And when do you think the results?
It'll be 5 years.
5 years, but that will give us a bit more clarity on that.
It will. I mean, there are issues, of course, with doing randomized studies, but it is officially the best evidence we can get.
Yeah.
And of course, we have our biases, and this way we can answer any critics with that.
The last question is, what are the common things you go through as the pre-op patients should be aware of? Just like any major surgery, what do you go through?
I think, as you say, Benoy, it's not to be sniffed at. Any hip arthroplasty is major surgery.
Yeah.
The risks and complications of hip resurfacing are only subtly different to a total hip replacement, and your listeners will be well versed with all of that. The only thing that we add, in a way, is that patients have a risk of fracture to the femoral neck rather than a prosthetic fracture further down when it comes to a total hip replacement. Loosening and limb length discrepancy and nerve injury and blood clots, they're all in the same realm as a total hip. The vast majority of it is that it's really thinking not about what the risks and complications are, but accepting that this is a novel technology that only has 7 to 10 years of data compared to hip replacements, modern generation, which has 20 to 30 years of data.
Thank you so much for your valuable time. So for listeners who aren't interested in seeing you in your clinic work, could you give our listeners where are you based clinically and also where they can contact you?
Yeah, of course. So I'm based here at UCL Hospital, where you come to meet me today. Thank you very much. And also at Cleveland Clinic London. My clinics are in Marylebone and in Victoria. And our operating theatres are in Victoria. I'd absolutely encourage any of your listeners to get in touch.
You want to share your links?
You insist. It's 360 Hip. It's a great way to communicate and share what I'm up to and share my passion for hip surgery. I hope that comes through.
Yeah. Thank you so much for your valuable time.
I hope you enjoyed the podcast. I'd like to thank Mr. Karthik Logishetty and all the team from UCL for giving up their valuable time and sharing their insights. And I had currently treated a couple of patients and following ceramic hip resurfacing, and both of my patients have done really well. I'm surprised with the early results. And it's another exciting option for patients who want to get back to athletic activities. So if you want to know more about hips, the rehab, and also having a framework on dealing with these complex cases, we have a lot of upcoming courses in London, Manchester, in Holland, and also in Dubai. So check out our links below, and you can follow us, me at Function to Fitness and Callum at Hip Rehab Lab. Till the next episode, straight from the hip.